So good morning, everyone, and welcome to the live case of this morning, complex TAVR, prevention and rescue. Obviously, I'm very honored to be co-moderating this session together with our host, Professor Park. The panels are a little bit sparse still, but nevertheless, we hope that we have an interesting case. So we are transmitting from Los Angeles, from Cedars-Sinai. I guess we're looking at some cases with bicuspid aortic stenosis. Okay, there you go. Good morning, or good evening, rather.
Yeah.
Hi, how are you, Raj?
Good, Eberhard. Hello, SJ. Good afternoon from Los Angeles.
Yeah, good afternoon. I forgot, I get screwed up here with the times, honestly.
Good to see you. Thank you for joining us, Raji. All right.
Pleasure.
All right.
Thank you for the invitation.
All right.
All right, terrific. So we have planned to show you a couple of cases, and we will start with this bicuspid case. It's not an easy case. Let me go ahead and introduce our team. To my right is Dr. Aziz Ghali, our cardiothoracic surgeon, our youngest recruit in our interventional cardiology group, Dr. Akriti Gupta. Everybody knows Mamu, who's been with me for a very long time. We have Shilpa, who's our cardiology fellow, who's going to actually present the case. Jeremy is helping with anesthesia. Dr. Sid Singh is going to show us some echo images. And I want to acknowledge our staff, Billy and Christina and Amy and Mike, who are here. This is a complex case. So normally we don't do general anesthesia now as much. But this is very calcified, complex. So we have a heart-lung machine here. We have perfusion here. And we have a pericardiocentesis tray also. I asked, and it should be readily available. So Shilpa, can you go ahead and present our case, please?
Yes. Hello, everyone. So we have with us here a 76-year-old gentleman who presented with progressive dyspnea on exertion and NYHA class 3 symptoms. He has a known bicuspid aortic valve. Next slide. His cardiac risk factors included hyperlipidemia, no other traditional risk factors. Next slide. Baseline EKG showed sinus rhythm, a normal PR interval, and a right bundle branch block. Next slide. His echocardiogram showed normal BiV function, a calcified bicuspid aortic valve, and severe aortic stenosis with a peak velocity of 4 meters per second and an aortic valve area of 0.92 centimeters squared. Next slide. He had no obstructive coronary artery disease on CT and confirmed on angiography here. Next slide. Here we can see a 4D cine of his aortic valve, in which we can see the morphology of the bicuspid valve. It appears to be a type 1 bicuspid valve with severe leaflet calcification. Next slide. Here are his dimensions his aortic valve dimensions based on CT. He had an annular valve area of 500 millimeters squared, a significantly smaller LVOT of 400 millimeters squared. His sinuses were roomy, and he had no significant ascending aortic dilatation. Next slide. His coronary ostial heights were adequate at 20 millimeters, even with the bicuspid aortic valve, with low risk for coronary obstruction. Next slide. And his ascending aortic angle, as well as the lack of tortuosity in the aorta, make valve delivery favorable.
Okay.
Next slide. His iliofemoral anatomy shows widely patent and large caliber vessels suitable for transfemoral access. Next slide. And here we often use cerebral protection devices for our bicuspid aortic valves, and his aortic arch anatomy is suitable for deployment of this device. Next slide. So in summary, we have a 76-year-old gentleman with severe symptomatic aortic stenosis of a type 1 bicuspid aortic valve with excess leaflet calcification without a calcified raphe. Our procedural strategy is to pre-dilate the aortic valve and then perform a TAVR with a 26 millimeter SAPIEN 3 Ultra valve via right femoral arterial access, and we plan to use cerebral protection using the Sentinel device. Thank you.
All right. Thank you, Shilpa. So, as you may have some questions, we are just going to go ahead and advance the Sentinel device.
So Raj, thank you very much. It was brilliant, and thank you for the case presentation. At least there's there's one good thing about it, that, the patient has good left ventricular function, everything else is tough. And we're wondering, we had cases yesterday, Raj, and I don't know, keep just going while we were discussing and asking questions. Maybe you can ask a few. The first most important one, we have very, very heavily calcified choice of valve. We have been discussing this yesterday here. Can you allude to or bring us a little bit closer to your thoughts on why using S3 versus a balloon expandable?
So,
I'm sorry, self-expanding.
Yes. So I think that, what we feel is that you should use the valve that you're most comfortable with.
Yeah.
We've done almost 400 bicuspids now with the SAPIEN 3 valve, and we've come to understand, how to be cautious and how to use it. So that's the primary reason I would say that why we've actually used the balloon expandable valve. But I also want to state that the results with the self-expanding valve are actually as good. I think so. What we know is that when you carefully select patients, you can actually get good results in both. And I think that when you have very, very heavily calcified valves, is there an advantage to using a self-expanding valve? Perhaps, but I think often you end up post-dilating anyways, right, in some of these patients. So I would say that the primary reason for us is actually to go ahead and use this is our experience with this valve. So you saw in the last 2 minutes, we advanced the Sentinel device.
Yes.
And we deployed the 2 filters. It was all done real time, live. So just, and I think with these heavily calcified valves, we are waiting for the randomized clinical trial data from the protected TAVR study, which will be presented at TCT, right? The 3,000 patient study.
Yep.
But I think when you have these heavily calcified valves, I think Eberhard, both you and I are very, very biased towards the use of embolic protection devices. We'll find out what the data actually shows.
Yes.
But to us, it makes sense to go ahead and use it, especially if the anatomy is favorable and not hostile, which is what the case was here.
Yeah. We had a nice lecture yesterday from David, and he, as you well know, he's awaiting these results that we all are. But, he identified 2 patient groups
Jamie,
that are,
can you move like a 30 please?
that are at risk, which is bicuspid and valve. So very well indicated here.
Yeah. Now, so Eberhard, would you? I know that you are, that you've done all the pioneering work with the self-expanding valves. Oh, actually, I think what we forgot to do is we forgot to ask Sid to actually give us a tour of the valve. So Sid, can you go ahead and show us the important echo data quickly?
Sure, thank you, Raj. So, normal to hyperdynamic biventricular function. Let's take a look at the valve. Bicuspid morphology here with fusion of the right and the left coronary cusps. These valves tend to dome. That's why planimetry can be a little tricky in these cases. We did some 3D imaging, and based on that, our measurements of the sinuses, the STJ, the annulus, and the LVOT was close to the CT measurements, and we concurred that, a 26 millimeter valve here would be appropriate. As was mentioned earlier, definitely a lot of calcification, especially, in the region of the left coronary cusp here, slightly away from the raphe. Fortunately, the ostium of left main is okay and away from this. And again, the hemodynamic data we gathered supported a diagnosis of significant, aortic stenosis with a dimensionless index of 0.23. Otherwise, no other structural issues identified with the valve. Importantly, no mitral regurgitation or pericardial effusion.
Sid, thank you very much. Could you tell us the 26 is based on what kind of measurement?
Okay, so as you saw, the CT measurements were around 520, right? And then if you look at the LVOT, the CT measurements actually were much narrower. They came down to, what was the measurement? 398. Okay, so I think so. We 26 is the size because I think with 23, the intercommissural distance here is actually very large.
Yeah.
So I think that if you use 23 is certainly going to cause problems in terms of PV leak and maybe even possibly anchoring. 26, we feel, and we have to be very careful and we have to be conservative here as we go up. And if it requires 2 balloon dilatations, that's what we will do.
Yeah.
We'll go up slowly. So Dr. Galley is going to go up slowly. He's also going to look at the pressure gauge, all right?
Yeah.
So if you reach 5 atmospheres, we may back off a little bit, okay? And then, if necessary, we will go back up again.
Yeah.
So, I think when you go up too fast and, I think you risk, it increase the risk of root injury.
Yeah.
We are also going to pre-dilate here, which should facilitate the crossing of the valve, okay, with the valve system. And hopefully, I think that may also lessen the chance of aortic root injury.
Yeah. Raj, just one question. When you do pre-dilatation, the main reason, obviously, like what you said, is to ease the entry and the passage of the catheter. But could you, at the same time, use this as a sizing methodology or potentially see where the leaflets are going to? The good news is coronaries are high. I see that. But can you use this? And I would also like Raj to ask SJ, because obviously he's also had a lot of experience with bicuspids, whether he would agree with the procedure.
Yes, in terms of device size selection concerns of stills, we have used areas percent oversizing compare with just annular valve areas. So even in the bicuspid aortic stenosis, so we just use the same criteria. However, area percent actually relatively less than the tricuspid aortic stenosis. It's almost 5% to less than 5% anyway.
Yeah.
Right? Depending on the calcium. In almost all cases, we do pre-dilation with the balloon. However, the size-wise, we don't care about the big one, just a small balloon.
Small balloon, yeah.
To use the.
What balloon size are you planning, Raj?
So we are going to use 20, which is obviously too small to size.
Yeah.
Right.
Okay, but we wanted to also, I think that I don't want to use a 23 balloon. It may be a little too aggressive. The minimum dimension is 20, is 22. So we've settled at 20, and I think you're right. There has been an occasion where we have seen the calcium move in a really bad way, and we've actually decided not to put the valve in and say, okay, you know what? We are not going to do this case. So this calcium does seem bulky. Let's see how it behaves with a 20 millimeter.
Yes.
We are sort of taking the middle route here. All right. So are we ready with the pacer, Billy? Yes. All right. Pacer on, please.
Pacer's on at 180.
Okay, let's go up. And as you saw, this patient has a right bundle branch block. Off, please. With a long PR interval. So, we told this patient that whether he goes for surgery or whether he goes for TAVR, his chance of needing a pacemaker is relatively high.
Yeah.
Okay, I mean, I think, there are some centers that would actually do a pacemaker before they would do a TAVR. I know of those practices also, but we thought there was no reason to do that. I think this is an acceptable risk of the procedure here, that, he's got a right bundle and he's got a long PR interval. Okay, so you saw that we dilated, I think as we were talking, we crossed the valve, we changed the wire to the, we got the gradients. Can we show the gradients? Is it possible to go back and show the gradients? The gradients were high, but not as high as thought they would actually be. So, okay. Okay. So we are going to advance this. And as you saw that, this was, we can argue, actually, some people would have called this a type 0 bicuspid, but when you look at the cross-sectional images, you saw some fusion of the, and a little bit of a raphe, but obviously it was not calcified. It's not the raphe that is calcified, it is the leaflet calcium, that is abundant, and the calcium score was actually almost 5,000. So, which, right? I think when you have a combination of calcified raphe and excess leaflet calcium, things are the worst. But excess leaflet calcium, of course, that's where we've been humbled.
Okay, there we go with the valve.
All right, so we didn't have to struggle here to.
So, Raj, before you deploy your philosophy, if I may say, you deploy slowly. Is that correct?
Yes, we are going to be not unleashing the force, immediately, but a little bit slowly.
Yeah.
Yes, please.
And what height are you aiming for?
Okay, so I think our angle was, let's take the RAO 13, RAO whatever, 12, 14, and caudal. Yeah, I don't like the number 13. All right. Sorry. My wife has taught me that.
I just came from India, Raj, so I know about the stars.
All right. We'll take help from everybody, the stars and the moons and everybody else.
Yep.
The entire universe. All right. Okay. So let's see. So there's a little bit of parallax in the device. Okay. So let's just study this. I think it is worth spending a couple extra minutes here. Now the LVOT is small, so it may actually tend to push this up. Okay. But this valve has a good seal. The Ultra 26 Ultra valve has a different seal than the 29 valve, which goes all the way, almost half the height of the valve, because it's an Ultra valve. Let's take a picture, all right? Can you do a little rapid pacing, please? Yeah, pace around. Okay, inject, please. All right, off, please. Okay, what do you think?
Yeah. I think nice.
All right. So the key is to keep it there so it doesn't move up. Mamu, are you satisfied there? And what do you think, Aziz? Huh?
I think we are okay. We need to push a little bit harder than usual, but it's probably going down.
SJ,
all right.
You agree?
Right. I personally, I think a little bit higher position. However, it's okay in case of a bicuspid aortic stenosis.
Yeah.
All right. So the reason why.
All right. Yeah, but I agree with you. We'll try to keep it there and not let it move up. Okay. Yeah. All right. Sid, are you happy?
Yes.
All right. Okay, everyone. Yeah. Racer on, please.
Pacers on at 180 with capture.
Okay, let's go up. Yeah.
Great.
Okay, let's 5 atmospheres down. Off, please.
1, 3.
All right. How much volume? -3. Okay, so we just want you to know that we have not given the full volume here. We have given -3 cc. So this is actually a 20. It's a 25 millimeter valve.
All right.
Maybe a little bit less than that. Maybe 24.5.
Yeah.
All right, which is, I think that is 75 years old, okay? If he gets a good hemodynamic result, that's okay.
It looks nice. And I peeked at the echo, but also the echo looks nice. I don't think there's...
Yeah.
No, I agree. There is trivial paravalvular leak.
Huh?
There is trivial.
Trivial. We'll take
Paravalvulally,
trivial.
the valve looks well expanded.
I think
And on
so.
the-
Yeah.
And on the short axis,
And you can see how the calcium is, I think if we were more aggressive, then we could cause aortic root injury. So I think, as you
Very
can see
nice.
here, so I think the key is to sort of, to create the right balance here. You know what I'm saying? Between different.
There's no heart block either.
Yeah.
Yeah.
What's the the EKG like? Jim,
So
just
you can see the EKG. I think that nonetheless, we would.
that's right.
We would be vigilant with this patient when the patient is in the hospital.
Yeah.
All right. So right now there is no, and I think in the long axis, Sid, can you show us what is our how deep are we in the LVOT? So you can see we are not very much into the LVOT.
Yep.
Right. And I think maybe that is what has actually saved us from a heart block, at least right now. We'll see what happens later. But the good thing about balloon expandable is that the late heart blocks can occur, but they are not as common. Because, if anything, there is a little bit of recoil.
Do you use routinely transesophageal monitoring during the procedure?
So, I always say, tea is a luxury, and I think we were all spoiled in the early days of TAVR. And we then switched. There is a lot of pressure to not use general anesthesia, of course, and keep the procedure simple and improve the efficiency in the lab. So we have switched to, conscious sedation and transthoracic echo. But when it comes to patients like this, I think that it is best to do these patients with transesophageal imaging. That's what, I'm not saying all bicuspids, though we tend to have a very low threshold for bicuspids. But, I think that we feel that, see, this is where if you have aortic root injury, you can be very quick, you can be proactive.
Yeah.
And you can take care of the situation.
Yeah,
you know what I'm saying?
I think that's a good decision too, Raj.
Yes.
Particular case that you see the spear and the calcium in the sinus of our cerebral. So if you do go a little bit more aggressive, imagine it's maybe things could be a completely different. It's called a major adverse event. It's very close.
Okay. So what we will do is we will go ahead and retrieve our filter. All right.
You're not doing an injection, right? A root injection?
We can do that for you, but we have TEE. So why waste?
Yeah. Okay.
Why waste 10, 15 cc's of contrast, right? But if you want it, we
No,
will
that's
do it
fine.
If you think there are any teaching.
No.
implications there. All right. So,
I'm just used to it, so.
Yeah. No, I think, with this, as you saw, there is, if you want, we can show you other pictures also. You know what I'm saying? So I think of the, all right, terrific. So I think that you can see that the valve is it is slightly oval, okay? But that's okay. You know what I'm saying?
Yeah.
And I think the hemodynamics are good. There is no PV leak. And this guy's job is done, and hopefully when he needs another procedure in the future, we can actually, we may be able to do a TAVR in TAVR here because we are far away from the coronary. You know what I'm saying?
Yeah.
So that should not be an issue in this case. Okay, so hopefully he'll never need surgery. Let's hope so. Okay, so this is what, I'm going to go to the other room while Mamu and Akriti will close the groin, and we have another interesting case.
Raj, just one question with the Sentinel. If you retrieve the filters, can you have a look whether there's something in there?
Yeah, okay. In fact, Mamu will go ahead, and Akriti, guys, can you go ahead and show the filter? And
good luck. Thank you very much, Raj, for a great case. Thanks a lot.
All right, see you soon.
Let's open up the filter. So this side. Okay. Now hopefully you can see something. Okay. We don't know like whether anything inside or not, but there may be something in the very bottom part.
Yeah, at least there's a
Yeah.
little bit of a dark spot there.
Yeah, there's a little bit dark spot in here. I don't
Yeah.
know if it's the thrombus or something, fragment of the calcium. The other side,
Oh, yeah.
let's see. This side
Better?
there is something. Yeah, there's something inside, no?
Not sure.
Not sure.
Dr. Raj,
Okay.
Dr. Raj,
Microdebation.
Dr. Raj, Dr. Raj, can you hear me? Dr. Raj,
Raji went to the other room.
Can you call AV
I
and
think he
tell
may
them
be a
to change my
transition.
channel or something?
Yeah.
Anyway, so there may be something.
Okay.
Nothing.
Well, thanks very much. Really appreciate it.
We're just gonna close out.
Still,
Right.
I want to see the air tool up top. All right. I'm old guys.
All right, guys, can you see us?
Yes, we can.
Okay, all right, terrific. So it's it's a pleasure now to show you another case, and we thought we would show you a case of mitral valve in valve. So once again, to my left is Jubin Joseph, who's our stellar senior interventional fellow, a very gifted person from Oxford, Cambridge, and all the good places. To my right is Sean Gogia, who's who's our interventional fellow, advanced structural. And then we should have Dr. Gali joining us soon. We have Dr. Moody Makar, who's actually doing anesthesia. Dr. Singh is also here. And then, of course, we have Kelly, and we have Adrian, and we have Eileen. They're actually supporting us. So let's go ahead. Sean, please go ahead and present the case.
Okay.
I think we might have a little bit of an audio system problem here. Raj, can you hear us?
Can we not hear Sean?
I can hear you. Did you hear me or not?
No, we didn't.
I introduced the team. Oh, you
Yeah,
did?
Okay.
yeah. The team
Okay,
we got, but I think maybe good to go one slide back again because
Okay, yes, all right. So I just want to go
Yeah.
ahead and introduce our team. Can you hear me now?
yes,
All right, okay, so I just want to introduce our team members. You know, our senior interventional fellow, Jubin Joseph, and I had sung his praises. Last time I actually introduced him. We have Sean, who is our interventional fellow. And then Dr. Gali should be joining us. We have Dr. Moody Makar, who you might know, who is actually doing anesthesia and also some imaging. We have Dr. Singh from ECHO as well, who you met and heard from in the previous room. Terrific. And then I just want to introduce our other team members. Kelly is here and Adrian is here. And we have Kylene there as well in the control room. So Sean, please go ahead and introduce our case.
no sound.
No
Oh,
sound,
no
eh?
sign.
Okay, all right.
Okay.
So, maybe Jubin, you can go ahead and present.
Okay,
Okay,
so
now-
sorry about that.
Can you hear Jubin?
Yep.
Can you hear me?
Yes.
Okay, so we have a 76-year-old gentleman with heart failure symptoms, NYHA class 3. He's previously had a mitral valve replacement with a 31mm Hancock 2 valve. At that time, he also had a tricuspid valve repair with an annuloplasty ring and exclusion of his left atrial appendage. Next slide. He has atrial fibrillation and he's a former smoker, hypertension and hyperlipidemia. Next slide. This was his transthoracic echo, which we did following his heart failure symptoms, and that shows significant mitral regurgitation of the bioprosthetic valve together with a mean gradient of 12 millimeters of mercury. Next slide. His angiogram demonstrated that his coronary arteries were unobstructed. Next slide. We did a CT measurement, which is critical in all mitral valve and valve procedures. We'd measured his annular area at 660 millimeters squared, and using modeling, his neo-LVOT was greater than 590 millimeters squared. His aortomitral angle appears favorable for mitral valve and valve procedures. Next slide. We also always check with the devices in the mitral valve and valve app, and here with the 31 millimeter Hancock, we have a true ID of 26 millimeters. We also see the fluoroscopic demonstration of the valve, which gives us an idea of how to land the valve. Next slide. So in summary, we have this gentleman with severe symptomatic mitral regurgitation of a bioprosthetic valve. We're going to demonstrate to you mitral valve and valve procedure with a transeptal puncture using the VALVES Versicross system, an atrial septostomy with a 14 millimeter balloon, together with a valve and valve procedure using the 29 Edward Sapien 3 bioprosthesis.
Great. Thank you very much.
All right, so let's see, either Sid or Moody can give us a little tour of the valve. Tell us what you actually saw on imaging.
Yes, so as you can see here in the bicommissioner.
Can you hear Moody?
Yes.
Yep.
Moody,
Everything
speak.
good.
Moody,
Yeah.
speak.
So as you can see in the bicommissioner view here, there's a severe MR, and it's projecting, and the main mechanism of it is a flare of this bioprosthetic leaflet back there. And then you're going to be able to see it here more on the 3D, and we're going to add the 3D color, how to ensure torrential and direct it more towards the lateral part of the septum here.
Very
so
nice.
we did the transeptal, and again, our transeptal location has been more on the inferior and posterior side. This is where we can get more orthogonal to the bioprosthetic valve when we're doing it.
Yeah.
Okay, terrific. Okay, so, what we want to show is, I don't know how many people there are familiar or how much the Baylis Versicross system is actually in use. So this is our go-to transeptal system. Okay, so essentially you can shape this. Is that our right atrium large?
The right atrium is large, yes.
Okay, all right. So in which case we would actually, give more shape. All right. So but in this case, when we did the transeptal, we didn't really have to do that. So what Moody is showing you here, before we started that case, we just, we're in this room. On the left in fluoroscopy, you are looking at where the tip of our needle is. So what we like to do is we use that as a guide, because imagine that circle of the valve. So you are actually, you're aiming towards the septum there, and that sort of, you can imagine what the pathway of the wire and the catheter would be.
Yes.
All right. So if you are very high there, then you are too high and you're going to get in serious trouble. So that's what we did. Now, so what we do is, and then there is this tree-shaped wire, which is the Versicross wire, which is what you see on fluoroscopy. And I have to say that the transeptal puncture has become so predictable and a pleasure, with this system. The advantage of this wire is, and we use it for appendage occluders, we use it for MitraClip, and for everything else, you can track all these big catheters, including the bulky MitraClip catheter, on top of this wire without any problem. So it saves exchanges. Okay. So, all right. So we've done the transeptal puncture. And we have the Versicross wire in there. Now what we are going to do is we are going to go ahead and gather some hemodynamics. So I think we have about 20-25 minutes. So let's do so. So why don't we go and put the Agilis catheter? Okay. So one thing is for sure, we have no controversy about what type of valve to use here, right?
No.
It's
That's okay.
It's balloon expandable. Yeah. All right. So I think.
Right. Any comments about the transeptal puncture? Is this what you always do when you do a valve and ring or valve and valve mitral?
Yes. So essentially, you want to be inferior and you want to be posterior.
Yeah.
That gives you the best trajectory. Okay, when you're high, it's like, your catheter has to go up and then come down, and I think it's a little bit of a problem. So bring this in, please. Yeah? Okay. All right. So we should take out this wire. All right. Now
Very well,
what we will
please.
do is, okay, we will advance a pigtail catheter. So Moody or Sid is going to help us. Okay, you can see that we are positioning this on top of the valve. You can see that, right? You can see the 3D picture?
Yep.
Right? All right, so I think
this was not.
then we will take a pigtail catheter and we will take the J wire and we should be able to cross it.
Yeah.
Right? So we are not doing this blindly. This is guided by imaging and hopefully it will not be hard. All right,
Looks
see that?
very nice.
Okay, all right. So now we will give you hemodynamics. So we will give you the left atrial pressure, which we are going to measure from the Agilis catheter. And we are going to give you the left ventricular pressure, which we will get from the pigtail catheter. Now, for the audience, I think it's important to point out to them that this valve is the Hancock valve, right? So the three eyelets that you see, at the bottom, those are the markers of the posts. And then the ring is which is where the base of the valve is. So when we are trying to position the valve, we are going to position it in such a way that the lower part of the valve, when we are trying to adjust the height or the depth, aligns with those markers. Now, one of the other things that we wanted to say is, I think if you looked at the CT as Jubin was presenting to you, one of the things that you're always concerned when you do mitral valve in valve or valve in ring is it going to cause a problem in terms of LVOT obstruction? Now, LVOT obstruction is generally not that common with valve in valve. It does occur occasionally when you're in really tight quarters and you may end up doing, a lampoon procedure or a septal ablation. But that doesn't seem to be the case here because there was a lot of gap. The neo LVOT area was almost like 500. 500, more than 5 centimeters. So that is not a concern here.
Yeah.
Now, the other important thing is that when we have mitral regurgitation through the valve, often we may not appreciate paravalvular leaks. So we've had situations where there is so much valvular regurgitation that we don't appreciate paravalvular, and then we put the valve in, and then we actually see that there is a PV leak as well, and then you have to go and deal with it. It seems unlikely here in the careful imaging that was done by Sid and Moody, okay, but we'll see what actually happens. All right. So can we go and show the hemodynamics, please? All right. Can you change the scale? Change
scale 50
scale. All right. And if you can go to more rapid so that go to more rapid speed. I want to see lay it out.
Increase the sweep speed.
Increase the speed.
Yeah.
All right. So you can see how big the V wave is, right?
Yeah, we can see that.
Is almost 50, 55, and then you can also see a gradient, even end diastolic gradient. So this is a combination of severe MR and MS. All right. Okay. So now, what we are going to do is we are going to take the extra small safari wire and replace that, okay? And then, okay, so let's do that. And at the same time, what I will do is get rid of the flexion because as we, push it into the apex. All right. Okay, so yes, okay. Okay, can you walk it back?
Yeah.
All right. Okay. What Mamu is trying to do is make sure that we see the apex of the heart. All right, so that we don't pull it out the wire accidentally. Okay. All right. Now, Jubin, as soon as this comes out, please walk the Agilis catheter
You want
back.
to do the balloon through it?
Actually,
Actually, it's a good point.
That's
We will use the Agilis catheter to support our balloon as we do balloon septostomy. So
it's actually a
we
very
typically
important.
go ahead.
Yeah, it's a very important remark that Rai just said. Watch the wire at the apex. Don't lose the wire position in the apex for various reasons. I think it's small comment, but it's very important for the ones that are not that familiar with the procedure. Thanks, Raj.
Yeah. Okay. So, we go between 12 and 14, in terms of dilating the septum. All right, so Jubin, go ahead and advance. So we will actually use a 14 because this is a life case. We don't want to struggle, and it's not a lot of difference between 12 and 14. Okay, so, all right. Okay, take this back. The question is, are we across? Okay, all right, let's go up and see. Mamu, take this up, please. Okay, Muri, do you see, are we too much on the left?
No, I think you.
Where is the waist
We
here?
need to go a little bit in.
A little bit in?
Yeah.
Okay, are we too much in? Okay. Okay, let's not lose track of time, guys. Muri, give us some comments.
Yeah, I think it's a very, very good. Sometimes it's difficult to visualize the whole waist, but we're trying to look at the balloon here, and
Okay, I am a little bit. Why did we not see a waist?
Maybe a 2.
I think the balloon is back here. See that?
Going to push into.
So the balloon is outside here, so we need to advance.
Okay, go up.
This is better.
Yeah, go up.
So
I feel a resistance in here, so it should be.
I think the
Maybe
balloon,
a little bit more.
Okay.
Like a waist in there. I think you need to go a little bit more further.
Yeah.
Close to the valve.
That's good. Let's see. That's it. Now you start seeing a little bit more.
Yeah,
Now you-
that's a
Now
good
we
one.
see a waist. See, otherwise we'll be struggling with the system. You know what I'm saying? So I think, yeah,
You can see the balloon.
just stay up for a
2.
yeah. Okay, yeah, stay up for a minute.
Can you put a pacer in, Raj?
Yeah, okay, so we are going to use this time to put a pacer in.
That was a good tip, Raj. You have to see that waist to know where you are.
Yeah. 1 second. Let's see.
Yeah, do the tricuspid.
So there is a tricuspid ring, that this patient
Should we
has.
test that pacer?
All right. Can you test the pacemaker, please? No, there are people who deploy mitral valves, do valve in valves without actually rapid pacing. Yeah. So I don't know, but we tend to use it.
But I think
Did you?
No,
I think it's captured.
Yeah, it's capturing. It's just he's
Okay.
a little tacky.
Too fast.
Good. All right, I think we can come down now, guys. Okay, so the other thing to remember is that a lot of surgeons, when they do mitral valve replacements and tricuspid and all those things, they will repair the septum and fortify the septum somehow because they go transeptally and they'll put patches, and that becomes a challenge at times. So I think one of the first, so that should be on your checklist. When you're prepping these patients or working these patients up. You look at their septum and see whether that has been done, because then you're prepared for the extra time and effort that may be needed. In this case, that wasn't the case. All right. Now, where is our, okay, let's come out with this balloon. Where is our pressure from the micropuncture?
Yeah, we'll give that in a moment.
Okay.
We had it for the gradients here.
Okay, very good. Let's walk this out. Okay, so Jubin is walking this catheter out now, the Agilis catheter, while I'm just holding the sheath.
So, Raj, in case there is a patch, what is your tip
Yes.
to cross? Are you trying an error or electrocautery or something?
Always electrocautery. I mean, I think it's much easier to do that,
Yeah.
and then you use a good balloon like Armada, Atlas, whatever, so that you can invest proper time and pressure in dilating the septum. Mm-hmm. Because that's the step, right, where you may have to, if it doesn't go, you have to come out, you have to waste a valve, or change the sheath, all of those things, and so a little bit of patience and a little extra time investment of 1 or 2 minutes, we feel is generally worth it.
Yep.
So I hope that was the case here. So let's hope that this will actually will cross.
So we now have aortic command.
All right. Okay. So now what we have to do is we have to assemble this valve, right, in the inferior vena cava. All right. So I think one of the important things, for teaching purposes is, that when we use the system and when we use the retroflex catheter, the retroflex catheter comes like this around the aortic arch. So because you're rotating the retroflex like this in a clockwise direction. Now, what we want to do is we want to just do the opposite, right? We want to go and make a retroflexion in the right side into the left atrium. So what we do is, the Edwards logo is not up, it's actually down.
Yeah.
As we will advance and as we will spin the retroflexion wheel. All right, so that's an important thing to remember. Of course, it's very important to remember that you have mounted the valve in a different way, not the way you would actually do a retrograde or the usual transfemoral TAVR procedure. All right, so I think those are two very, very important things to remember. Okay, so now we will advance this. Now the distance, from the right atrial septum to the groin is actually much shorter, right? So we may have to do, so you can see here, we don't want to go across the septum. So, and here you can see that we are still in the sheath. So what we will do is we will actually withdraw the sheath back, okay?
Yeah.
So we will assemble. Now, as we are assembling, we want to make sure that we don't pull the LV wire back, okay? Yeah, so assemble, please. Assemble. I don't want to go, with the tip across the septum.
I'm very slow.
Yeah, okay, so, this is where if you are rushing or whatever, you can lose the LV wire and things can come back. Okay, all right, Sumamu, go ahead and lock it and... Okay, so as you can see, we are assembling the valve. Okay, keep doing it, keep going, please. Keep going. More. All right, okay. So now,
41.
Wow, that was nice.
all right. Yes? Okay, so as you can see now, the ring, which forms the base of the valve, is like a straight line now, all right?
Yes,
And the three posts are all in a straight line.
correct.
So if you were to use your imagination, this valve is almost rectangular, right?
Yep.
I mean, in looking in, all right? So that is what you want to do. You want to be, so that is your view, all right? So our valve is aligned with the lower posts, okay? And as we come up, and we should remember to bring back this adequately. Okay, so Jubin, you come in the front here. I'm going to hold this. Okay, so okay. All right.
So you
are we all ready, guys?
You fine-tune while you deploy, correct?
That's correct. See, it's always easier to push in. It is harder to pull back.
Yeah.
Okay, so I like to be like this a little bit.
Understand.
And we'll go up slowly, and that'll give us time. So even though this doesn't look perpendicular right now, it's okay because it will become coaxial.
Yes.
Okay, Floro, please. All right. Okay, so let's do this, guys. Yeah? I think this pusher is back far enough.
Okay.
Yeah? All right. Pacemaker ready? Are you ready? Okay, pacemaker on, please. Sane? Okay, let's go up, please. Yeah. Very good.
Very nice. Very, very nice.
Down. Okay, off, please. All right. Okay. All right. So very good. Okay, so we are going to now. So can you tell us what?
So
Okay, we're going
all of this, the leak is coming from the intravalvular, from inside the because of the balloons, and you can see here the position of the valve is very well. We don't see any paravalvular leak. It's mostly just because of the wire, and the leaflets are moving very well.
I think we'll take this.
And we don't see any LVOT gradient or acceleration of the flow. We're going to measure the gradient in a second.
It drops with an MPA, yeah.
But so far, looks it's very good deployment here, and I'm going to show it in the 3D. Second
The
too.
MPA in an injection.
You can see it's very, very nice looking.
You don't want to put the Agilis
With an MPA, yeah.
with an MPA.
So that'll get across the septum.
Yeah.
And
And then we put the color to it. We can barely see any color coming from it. It's just because of the restriction. That's it.
All right. So, okay. So what we are doing is we are going to reintroduce the Agilis. Okay. Shubin, go ahead and advance the Agilis and the.
So this is exactly how you wanted to position the valve.
That's correct.
Beautifully done.
So, okay. All right. Very good. So what we've done is we've re-advanced the Agilis catheter with the multipurpose catheter back because we want to get gradients. All right. And also we don't want to just yank out this wire with the big curve. You know, we want to do that. So we put a multipurpose catheter. So this is fine. But also now we have the luxury of getting the hemodynamics. Yeah. So we will use this, which is the multipurpose catheter, which is across the valve in the left ventricle, and the Agilis catheter. Just like we did, you know, when we first got the hemodynamics, we had the pigtail catheter and the Agilis, and now we have this. So that'll give us the hemodynamics. Now, did we see any PV leak? I didn't see any, right?
I can see it.
So there are no surprises.
There's some air in the atrium. So
Raj, is there a role for fracturing these valves?
Yes, I think our friends in Kansas City actually, you know, are big advocates of fracturing these valves, and you know, they tend to do that quite a bit. But I have to say, we have not really taken on to that, and I think maybe because, you know, we not too long ago actually we did a case where we did a valve in valve, and this patient actually had MAC around the surgically implanted valve, and we were surprised. This patient ruptured. Even, you know, we did a mitral valve in valve, and this was one of these valves. What valve was that, Jubin? Do you remember?
it was also a Hancock.
It was a Hancock. It was a Hancock valve. It's actually interesting that we actually had annular rupture in the MAC surrounding the surgical valve. So, you know, I think that it gives me a little bit of pause, you know, in terms of
50.
wanting to fracture them. Generally, these valves are larger valves. So I would think that, yes, occasionally when you have a smaller valve, you may want to do that, but we've been cautious about it. So you can see now the V wave has come down to about 20, right? It was more than 50. Actually, you know, let's see if you can get the PVCs out a little bit. So you can see the V wave is anywhere from 15 to 25, okay? And you can see that the gradients, right? The gradient is practically down to nothing. So are you able to see the hemodynamics?
Yeah.
Can you
Yeah, we can
change
see that.
the speed, right? Okay, so I think those are the hemodynamics. So I think, you know, good. I think we can come out of the ventricle. We don't need to tickle the ventricle.
So, Raj, Jim just pointed out there's a little bit of an EKG change. Can you explain that?
What is going on, guys?
no, we had some ST segment, elevation, so we had to bring the pressures up.
Huh?
We had some air, so we had.
So
some,
you think there was some air that
Yeah.
went through catheter exchanges?
yeah.
All right, let's just support the pressure and bring the, so I think occasionally, that's one of the things of working in the left atrium, you know, when you're measuring hemodynamics and you're flushing things, this will happen occasionally. So we have to be very, very careful. All right, so the pressure is not bad. Okay, it's about 100. So we'll let it settle down. Okay, so we'll let that settle down. Okay, now do you see anything else around the valve, around the heart, just to be careful, just to be sure? The valve is good?
I think, as one thing that has changed, and we've slowly learned this over the years, when we take away mitral regurgitation in these patients with failing bioprosthetic valves, the LV shrinks. And in many of these patients, the right ventricle can be scarred for whatever reason, they've had a bypass run and so on. So, if they get very tachycardic, we can see transient RV dysfunction. Obviously, this person has so at times air can also get into the coronary.
Yeah.
But I think something we just have to be cautious about, RV dysfunction after deploying these TMVRs in prior valves.
Yeah. Okay, so I think at least there's not anything functional, right?
Yep.
Okay.
So we are supporting the ventricle, the right ventricle right now. That's it, pharmacologically.
Okay.
The valve structurally looks very intact.
Okay, so our pressure is a little high.
Yeah, it's gonna start to settle down.
Okay, all right. I think it'll.
Yeah.
But that the high pressure helps the air get out. So I think at times you do that. Yeah. So RV can be tricky in some of these patients, and I think you have to support them through the. Okay. Okay, so I think let's, so at least a little tachycardia here and some.
The STs have normalized.
The STs are normalizing now.
Yeah. You saw that.
So I think, so I think the STs, okay. All right, so I think that, do you have any other questions or comments about, we are told we have only 3 minutes left.
Paul?
Yeah. Can I ask you, do you routinely close the ASD because the hole is actually quite big?
So I think the question is, do we routinely close the hole? In this case, if the RV is, distressed, if it continues to be distressed, then we will. Now, the only time we normally consider closing the hole is if there is severe tricuspid regurg, and then we see bidirectional shunting, and there is hypoxia, so that's one. And then I think the other reason to close it is when there is RV dysfunction. So often we will watch these patients on the table for a few minutes and then decide, whether or not we will actually close the ASD. But normally that takes 5 minutes, right? So you can just take a 25 millimeter GO device. That is our device that we normally will go ahead and use, and we will actually close the hole.
Raj, what's your anticoagulation strategy?
So you can see now that the EKG is much better, and the heart rate is also relatively, compared to what it was, still a little tachycardic, but I think we are, seem to be moving in the right direction. Yes, we will give anticoagulation, a couple days later. We will start the patients either on warfarin or on a DOAC and use it for 6 months.
Okay. Any other SJ? Okay, SJ is happy. If SJ is happy, we are happy. And thank you very much, Raj. Brilliant transmission from Cedars to both teams. Very, very instructive, very insightful, very successful as usual. So thank you very much, and we give you a big hand from here, okay?
Thank you. Thank you.
Thank you very much.
Great cases, right?
Thank you.
Okay, so we move on to the lectures, and I think the first one is a recorded lecture.
All right.
A recorded lecture from Hong Kong. And he will be talking about Asians and small annuli, a very important topic. And is he ready to go?
All right. Ready?
It's going to be Dr. Lam from...
Thank you for the invitation of AP WAF for me to give a talk on this topic, TAVR procedural optimization for Asian patients with small valve size. First of all, the definition of small aortic annulus is very important because we want to know what are the cutoffs But unfortunately, there are many cutoffs depending on different cohorts. But most commonly would be based on the area. The cutoff is 330 millimeters square. So this is based on the charts of the balloon expandable system, like the S3. So any annulus the size smaller than 330, we would consider a small valve like the 20 millimeter. So this is a commonly used cutoff. Some people will use a 314 millimeter as a cutoff, but more precisely, we should define this as an extremely small annula. Some other authors will use the mean diameter as the parameter to define a small annulus. So we usually seen people using a 23 millimeter the cutoff for small annulus and a 21 millimeter as a cutoff for extremely small annulus. This is more applicable to the self-expandable system, in which when the annulus diameter fall into this areas, the annulus size, then we may use a very small self-expandable valve like the 23 or at most 26. We know about comparing with European population. Asian population have a smaller aortic annulus diameter. And so people would think that the issue would be patient prosthesis mismatch in this area, in this cohort. But sometimes it will be very difficult because the calculation would also take into consideration of the body surface area, and in which, for Asian, they also have a very small aortic annular body surface area. So before doing TAVI in a selected case of a small aortic annulus, we should really try our best to verify that they are really true small annuli to start with. So we usually use adjunct imaging, for example, TE, when we see a measurement of a small annuli in CT. And in some selected case, we may use balloon testing. This is not something that we commonly do, but in this case, for annular area of 250, we use, before we put in a 20 millimeter S3, we use a 16 millimeter balloon to test it. And it seems even for a 16 millimeter balloon, the annula is tightly sealed off and with a lot of tensions around. So in this case, we decide to put in a 20 millimeter. What are the challenges for small aortic annula? First of all, from the surgical experience, it links to higher mortality and more ischemic cardiovascular events and stroke. It increased the risk of prosthesis patient mismatch, which in turn leads to increased in perioperative and overall mortality due to suboptimal valve hemodynamics and less LV mass regression after AVR. So there are many surgical ways to tackle, for example, root enlargement, put in a standard prosthesis with supraannular positioning, and use of standards for prosthesis or sutureless valves. From the Japan, our experience, this is a JTVT registry comparing small annular size and also normal sized annula to undergo TAVI. Echographic outcomes, it is not surprisingly to see that the erective orifice area will be less for small annular going for TAVI, and also with a higher residual gradient. And this study, when comparing as S3 and E-fluid, it seems that it also links to better hemodynamic outcome with the self-expandable valve. However, for prosthesis patient mismatch, there's no statistically significant difference between the two. So this Ocean TAVI registry, it showed similar results. Using A-fluid seems to be superior to S3 in terms of hemodynamic performance, but there's no differences in all-cause mortality. For PPM and this study, it shows that if it is an extremely small annuli cohort, for moderate PPM at 1 year, it is a statistically significant occurrence of moderate PPM in patients putting in an S3 compared with E-fluid. So what are other concerns for TAVI in SAA? So mainly will be the risk associated with TAVI, including risk of annular rupture due to relatively valve oversizing, the dense calcifications, while we have a relatively small area, and low body surface area, which is associated with the overall anatomy for the patients. Risk of acute coronary obstructions, vascular complications, accompanied with small femoral arteries, difficulties in filter coronary access, and filter management of TAVI and TAVR. Techniques to overcome these problems and best is to optimize TAVI. For S3, I usually implant relatively higher And to improve the hemodynamics, if allowed, we would consider supraannular TAVI like Evolut. We have to optimize the frame expansion by adequate pre-dilatation and post-dilatation. And if it is a case of S3, we may add in extension of volume as appropriate. Selection of valve, yes, we tend to use some valve to have a better hemodynamic performance, but we have to take the whole aortic valve annulus complex into considerations because they usually, not only the annulus is small, the SCJ, sinuses, alveoli are all small. If you put in a supraannular valve, then that may be too big to that anatomy, and the metal volume or the metal occupying that area will be a lot. So we would have potential effects on future coronary access and also future problems with valve TAVI. So there's one example of a patient with small annuli just to illustrate that the vascular access will also be small, which is proportional to the overall body size. So this is in a case with a small aortic annula, 280. So this is the case is straightforward with not that not a lot of calcium. Then in this case, you can see first we put in a 20 millimeter valve, but we put in additional volume to start with in a delivery system. And when allowed, we put in additional volume with the post dilatation. You can see this appearance of the 20 millimeter S3 is optimally expanded, and hopefully that could improve the hemodynamics. And it is slightly higher implant with more foreshortening from below. The valve is slightly more supraannular. So this is a patient with a small aortic annuli. And on the contrary, sometimes we can see this patient, small annuli associated with a lot of calcium and also calcifications at the STJ. We try to optimize it, but there may be limitation. First of all, there's some recoil or limitation of expansion. But in this scenario, we have difficulties in further expanding it because you can see that the edge of the valve is touching the STJ, which is very calcified. And also, it has some risk of coronary obstruction as the level of the valve frame is at the level of the coronary ostium is a bit close. So far, it's okay for this patient, leaving behind a 12 millimeter mercury gradient after 5 years. But we still have concerns. We have to closely monitor this patient, and we also may have issues putting in the second heart valve in case it degenerates along the road because of the risk of coronary obstruction. So these are the potential issues that we may encounter. So these are examples of using Evolut in patients with small aortic annuli. And just to illustrate that there's no special technique, but just to optimize the results by carefully pre-dilatation. When deployment, before full deployment, we check the coronary patency to do protection as necessary. And the results is very good, but you can see the amount of metals around this area, which may have issues in future coronary access or TAVI. So accurate neo is something that we use. This patient has a small annuli, but is a big gentleman with it's a normal body weight or slightly heavy than the usual patients with a small annuli. So we use accurate neo for this scenario. And as usual, we do optimization with post-dilatation to optimize the gradient. And it remained a very low single-digit gradient at 3 years in terms of mean gradient. And in this case, it has some progression of the coronary artery disease. So with the design, although it's a small annuli, we put in a supraannular valve, but coronary access is less of an issue when using this accurate neo, and the PCI itself is very safe and uneventful. So in conclusion, small or extremely small aortic annuli was commonly seen in Asian population. First of all, we have to verify the measurements, and we have to take the whole aortic valve complex into consideration. It's not just annulus, but also the anatomies around. So if we decide for TAVI, we have to optimize the procedure outcome in terms of techniques. We have to avoid complications, and sometimes careful device selection is important for our patients. And the heart team evaluation is important. Whether this patient may be indeed going for surgery may be better to start. But overall, we also have to manage patient factors and expectations. For lifetime management for TAVI, systemic and careful long-term follow-up is also very essential. Thank you very much for attention.
Yeah, thank you very much. And we keep going. I think, Alan, it's on you now. I don't think Professor Young needs any introduction. He will be talking about balloon expandable valves, new understanding about sizing, positioning, and repeating.
Thank you very much, Eberhard, and it's a pleasure to be back in person in Seoul, obviously. So this topic was given to me, and I thought about it quite hard because we know from many times when we look at doing like many of the live cases today and yesterday is that it seems like it's a very simple procedure. We put a valve in just like a stent and we inflated it and we kind of done and then pretty much that's it. So obviously that's obviously not, that's the sort of the end of the procedure, if you may, a lot of preparation beforehand. So what happened is that if you have the wrong size or wrong sort of calculation, you can end up with something that is relatively looking pretty benign after the procedure, such like any other procedures with a little bit of a leak. But if you pay attention to a little bit, there's a little bit of a stain sort of start to build. And a few minutes later, if you do a corneal angiogram, you can see that there's some sort of thing going on here that is related to the circumflex. And obviously from top here, you can see there's some staining. So there's a supraannular rupture here. Also, you know, these one and done type of procedures, you can, looks pretty simple. You can see that sort of the valve pops up if you're not careful pushing the valve down. And at this point, you hope for the best, but when you see the valve sort of turning, you know that the valve is now actually loose. And you have to figure out now what you need to do is valve in another valve, or how do you prevent this valve from migrating south. And going north is not so difficult because going south will be a problem into the ventricle, for example. So we all learned from doing many years of balloon expandable TAVR is the sizing is, you know, nowadays clearly based on the sort of cut CT and essentially looking at systole, the maximum annular area. Obviously, many other measurements will also play a role, but in terms of picking the size of the valve, this is the primary measurement. And we obviously have the dimension of, for example, the SAPIEN 3, we have the nominal area. So therefore, the oversizing that we talked about is really this nominal SAPIEN 3 area divided by systolic annular area. So just have to remind you that this is a theoretical oversizing, the maximum oversizing, because just like balloon angioplasty with a stent, that depends on what is the compliance of the valve and how willing the valve is to stretch. You may not reach this oversizing, or if you are too aggressive and there's too much volume in the inflator, you could actually now oversize as well. So this is a guide, sort of a guiding point that this particular valve at this inflation volume will be the percent oversizing. So what is the issue about sizing? That this is sort of some of the older data 10 years ago, for example. The major concern is that if you have sizing-wise, either have oversizing or undersizing, you could obviously have perivalvular leak or perivalvular AR. And obviously, if you have undersizing, this percentage will be higher, and less with oversizing, and low with probably around 10%. This is kind of the older data using the SAPIEN XT valve, for example. But it's clear that once we move beyond the SAPIEN XT into SAPIEN 3, which has a cuff at the bottom, that as you look at the percentage of oversizing from less than 0 to 5, 5 to 10, greater than 10, the SAPIEN XT in this orange bar and the SAPIEN 3 in this gray bar, that you certainly have less chance of mild or greater perivalvular leak as you reach about 5 to 10% of oversizing. So if you look at some of the sort of data, which is from partner 2, S3 intermediate risk, same sort of a phenomenon. You look at clearly that as you increase in terms of the percent oversizing, reaching 5 to 10% or slightly over 10%, you may have the best chance of avoiding significant perivalvular leak. This slide shows a little bit more detail. I think that's important to understand that if you reach between 5 to 10% or above 10% in the S3 valve, that the chances of having mild to moderate perivalvular leak is now in a single-digit range, and above 10% is about 4. And if you combine sort of the mild to moderate, it's about 11% in 5 to 10. So the holy grail is to really reach about 10%, and obviously without other complication to avoid perivalvular leak. But we now don't use the S3. We all pretty much now have migrated to the S3 Ultra. And what does the S3 Ultra do? The S3 Ultra, as you all know, has an outer cuff a little higher that hopefully seals the annulus a little bit better. And this is shown in some data. For example, here, SAPIEN 3 in terms of the percentage of having mild or moderate perivalvular leak. S3 is around 14.3%. And if you look at S3 Ultra, it is now down to about 9% for mild, very little greater than moderate. So what does cuff really do is that for the same amount of area expansion, that now you have a better chance of sealing and therefore doesn't have to oversize it too much. This is a recent data that was published in April. Basically look at all the S3 versus S3 Ultra data, clinical outcomes, as well as what we are interested in here is perivalvular leak. So for example, if you look at the mild perivalvular leak, the S3 about 28.4%, and S3 Ultra is down to 13.4%. And if you look at moderate to severe, it's really down to less than a 1% range for S3 Ultra. So again, the cuff serves a purpose that you do not have to oversize as much likely. So this is a chart that, for example, Simon showed quite a bit. It is what we use day to day to look at what range of coverage of area. For example, here showing different area sizes, and also if you put in a 23 in green here, what would be the percent oversize in this nominal measurement again. So here, as you move to the higher area, you start to looking at minus in terms of the percent oversizing. But if you switch to a bigger valve, you obviously have significantly oversizing, 20%, for example, in the area range of 430, for example. So similar issue here on the overlapping size of the 26 to 29. And obviously on the high end of 29, there are areas that cannot be covered by the 29 S3. So this issue is that these circles represent area that is a little confusing, right? What exactly should we use, and what are we aiming for? And you heard all the different live case sort of discussion. Is that there's some fine tuning, a little bit of art of deciding what size you should use. So what are we trying to balance? If you use a larger valve and maybe somehow undersize or do something, you have lower gradient, but you have run into a higher risk of AV block because it's touching the septum more likely, and then you have potentially periaortic hematoma or annular rupture. The smaller valve have less of those, but you may have more perivalvular leak or malposition. If you tend to just not very calcified valve, you may end up embolizing. So obviously, annular rupture is not random. It's been shown again and again, LVOT calcification greater than moderate increase your odds ratio by 10-fold. And obviously, the prosthesis area oversized by 20% is also a risk as well. So therefore, there's two choices when you're in the border zone, is whether you should oversize a smaller valve due to the anatomical factors I just talked about, annular calcium, coronary obstruction concerns, narrow STJ, or also some anterior mitral leaflet calcification that might cause some harm to that leaflet. So you obviously can oversize. For example, in a 23 valve, you add 2 cc, which is essentially you have 5% oversize for an area of 430 now. So if you use a nominal fill volume, it's actually a 5% undersize. So you actually turn it around, have change of a 10%. So you can do that for 26 as well. The 29, adding 4 mils is really to not, relatively speaking, is not to cover a percentage oversizing, as many covering large area, large annulus. So how about also the other way? You can undersize the larger SAPIEN 3 valve, and very roughly, if you underfill the balloon by 5 to 10%, 1 to 2 cc, or you do not push the syringe down to the last 1 or 2 cc, your annular stretch will be reduced, your inflow size may be slightly reduced, and there's a little bit of effect on symmetry, and also, but obviously less risk of annular injury. So the question is that, this tunable system, which I think you have seen a couple of the tables from Asan Medical Center, is that you can change a little bit of the valve size, if you may, by, either selecting a larger valve and underfilling it, or a smaller valve by oversizing it. So this is still sort of an area that in S3 deployment that is still relatively dependent on the operator and a little bit of sort of art of tuning the valve strategy. So for example, here there's an LVOT calcium that's pretty heavy duty. So we undersize the valve by about 9%. You can see there's a little indentation of the top part of the valve. So slightly unexpanded, but no leak, and grading was good. So you try to minimize the risk in that situation. I think Eberhard showed this valve yesterday. This is the new Sapien X4 valve. There's a couple of things that are very interesting and specifically to sizing. So the frame, as you can see, this is now looking more like the sort of multi-link stents that we had before, that have ability to expand it without has to sort of really changing the geometry of the valve. So the idea this system is now you can tune the size a little bit more accurately or more precisely, and also maintaining the high radial force that you need. Obviously, there's a new PET outer skirt, and also we talked about the Resilia anti-calcification technology. So I'll go into the sizing a little bit because that's kind of the interesting part. But nevertheless, the part that is interesting also is that you can, these valves have these free aldehydes on top. If you can block it and put glycerol on top of it, so these are glycerolized tissue. Now you no longer have to put it into sort of a formalin to preserve it. You have a dry valve. So much easier to ship and much easier to preserve. We showed this slide yesterday. I think the important sort of message here is that, again, looking at the configuration of the valve, you can see the valve top here, the link between cells are now a focal point, like a stent in a coronary, versus these sort of large bars. So therefore, ability to stretch the valve slightly in a small incremental interval, I think is now more precise. So there's 5 steps in the 23. No longer we have a 20 millimeter valve. There's 5 steps in the 26 and 6 steps in the 29. So these are by diameter, even though we're still inflating by volume. What I showed here is the actual system. So there's a little pie chart, if you may. It's actually quite educational in a sense. If you have a valve area 480, for example, and you're choosing a 29 millimeter valve, you can see by pushing it to 25, you are talking about 2% oversize. If you go to 25.5, you have a little bit more of oversizing. And on the syringe now, these sort of cover allows you to decide how much volume you put in, but it's interpreted as a diameter. So you can go from, for example, 25 to 25.4, or you can go 24.5. So you have choices by doing this. And so therefore, this tuning is what we've been looking for, is turning some of that artwork that we had before into a more precise method of deploying the valve. So if you go to a certain volume, and I didn't take a picture of that, sometimes you have a choice between a 23 and a 26, and you can see the 23 have to be increased in a bigger diameter, while the 26 have to be a smaller diameter, and you have a choice as an operator depending on the valve configuration, meaning calcification, the sinotubular junction size. You can decide which valve to use. So the other piece that is of this valve is interesting is that there's a valve rotational control that allows you to align the commissure of the new valve. So for example here, yesterday you saw the Jenner valve, your typical standard 3 cusp view. You can see the right coronary cusp, left coronary cusp, and a non-coronary cusp. So the commissure of the left and non is the back of the right coronary cusp. So here in the system, you actually can turn the valve and align the valve with there's a little, maybe I skipped that for a little bit. There's a little letter C here that you can rotate, and it will be in the back, as you can see, as a C is actually in the back of the valve, and that aligns the left and non-coronary cusp. So now the technology is available to really be able to have commissure alignment. So there's a trial that we are participating. It's called Alliance, which is testing the X4 valve in the US. It has a bicuspid registry and a valve-in-valve registry, essentially taking all comers and looking at death and stroke at 1 year compared to the historical control using partner 2 and partner 3 using the S3 valve and S3 Ultra data. So these are the committee. My colleague Rahul Sharma at Stanford is part of the national PI for the native study. These are the study sites. Obviously, this is one of our procedure a couple weeks ago, one of the first one. This turns out to be a pretty horizontal aorta, so it's a little bit challenging in terms of getting the best three-cuss view, but nevertheless, this looks like the best one we can have. This is a little long in terms of the loop. You can see that there's a C in the back here, in the bottom where my pointer is. And we will turn from the outside, and you can see the C will start to rotate and come underneath and become a real C. You don't want to be a C that is pointing the other direction. You want a C that it looks like a C. So see, right now the C is now aligned. So now you know that the commissure in the back of this valve is in the three-cuss view would go towards the left and non. So I think we can go to the next one. This is just the inflation, pretty standard. The little shots, and you can see actually in here, for those of you who have used looking at S3, there's three little markers, which basically are the three commissures that now are labeled compared to before that is actually not seen well. So this is the final picture. Essentially, the position is quite good, and you can see the three little tabs at the commissures, and you can actually get better views of that. And this study has a CT subcomponent to really look at how good is this system in aligning the valve to the commissure. So in conclusion, the sizing of balloon expandable valve is tunable as it stands now, balancing between valve gradient, perivalvular leak, and annular injury. I think the key component is the calcium load of the valve, and likely determines the risk of complication and makes you decide how you tune the size a bit. And I think the SAPIEN X4 standardized this adaptive sizing strategy with a new frame design. So I think I look forward to seeing how the data pans out in the X4. Thank you.
Thank you very much, Alan. Great insight of what we have now and what we're looking forward to in the future. Any comments?
Yeah, Alan, I had a question for you. That was terrific. Calcium seems to be the enemy still of TAVR, and I think Eberhard touched on this yesterday. What's the role in the future of calcium modification to help settle some of these risks?
Calcium modification in terms of removing the calcium from the
pre-procedural. There's been lithotripsy, internal, external, for instance.
So actually, as you know, the shockwave was sort of worked out as a system at Stanford's valve design group, and one of the early thought is to actually have a balloon that basically can do balloon valvuloplasty without implanting a stent by cracking the calcium more consistently. So that potentially could be one way to test it, to see whether you can make a valve much better in terms of ability to expand a valve without causing injury. Can it be standalone? I think all that is still possible. There are obviously people working on trying to decalcify the valve, and I think that will be hard, like putting a balloon in one side or the other and bake the valve into some sort of solution. I think that would be a pretty difficult way to do it. You may be able to do it if you have one of the true balloon remember the true balloon has one that has a valve inside, and you could actually probably treat the valve like bathing it into a solution while your inside has a temporary valve working. But I think all those are like a big stretch, doing a lot of stuff for something that maybe not have a great return. So I still think maybe some sort of a balloon that is better in terms of anchoring, because as you know, balloon valvuloplasty, a lot of times if you don't pace fast enough in the old days, the valve squish back and forth, never get a good dilatation. So a cutting balloon type or something of the true balloon or sort of a shockwave balloon may be of help, but I would say the value is not great. So,
well, I mean, I was, if you recall, I was at that time together with Todd in Paraguay, and we did the first aortic stenosis with the shockwave. The problem there is that you really, the flowing blood takes the sound waves away, so it's quite a challenge to do that. But nevertheless, we don't like calcium wherever it is. It's giving us a problem, no matter what. While you're there, and we didn't discuss the small annular stuff, I'm still, to be honest, I'm still puzzled, and I wonder whether maybe you could clarify my mind a little bit. If we take advantage of if supraannular does play a role, isn't small annulus a good example of using supraannular valves versus balloon expandable intraannular valves?
I totally believe that, particularly if depending on the age of the patient and how long they're going to live, and you're not worried about TAV and TAV,
Yeah.
you'll definitely, get a better hemodynamic result, maybe a better clinical result in those really small annuluses that have appropriate sinuses for a bigger supraannular valve.
Well, SMART trial will probably answer some of the questions, but the Japanese physicians, surgeons, they're still implanting very small valves even today.
The other question, in the United States, there's been a resurgence of aortic root enlargement with surgery. So
Yeah.
if it's a younger patient, I would rather do my surgeon do a root enlargement and prepare for TAVI in the future than try to put a super small sapien or evolute in.
Yeah, I think, if I look at, all the 2,000 plus that we have done, I would say that the 20 millimeter S3 may be a handful of times. I just did one last week because there's a tiny Asian lady with kidney transplant and her valve is really small. That might be the, only, there's other issues that we shouldn't use a supraannular valve, for example. So I think default should be a supraannular valve like Evolute to start, rather than thinking backwards, right? You just think I should use an Evolute here. Why not? If maybe that's the better way to look at it, whether it is, small sinuses, whether it's, coronary obstruction, otherwise. But I think looking ahead too far, it's like, what should I do in 10 years? I think that might be sometimes end up hurting the patient in the short run if you're left with a grading of 25
Unless you're going to consider surgery as your first procedure, which I think
you
should.
Guys, I think Asa Medical is waiting. I think we conclude this session. Ellen, you can stay here and take over together with Jim, and we're going to Asa Medical to the live case.